Okay, for the next 15 minutes or so, we're going to discuss some of these endpoints of resuscitation. And this is where I come from. It's Richmond, Virginia. It's on the east coast of the United States in the middle. Level 1 trauma center admit about 4,000 patients a year, predominantly blunt, but we do have some knife and gun club, which keeps our surgeons happy. And I'm going to talk a little bit about the markers of adequacy of shock resuscitation and try to define what exactly are we talking about and introduce you to a concept that you're going to hear more and more throughout these couple of days. And this has been spearheaded by a lot of the senior professors here that are going to talk about it. There's the damage control resuscitation. And if you think about the patient in shock after severe trauma, and what's happening to them is that they go into the state of critical oxygen delivery deficiency. And so the oxygen consumption, oxygen delivery becomes independent, because of which they have to keep on getting more and more oxygen delivery to pay off this oxygen debt that they accumulate in times of shock. So this is a two-hit model actually popularized by Dr. Gene Moore quite a while ago. It talks about how it is important to recognize that the patients who have severe tissue injury or shock or severe host factors such as significant comorbidities have this severe inflammatory reaction, the so-called systemic inflammatory response syndrome. And if this is a major severe trauma and have a severe surge, they can go into this early MOF, or multi-organ failure. What usually happens to our patients is that they come out of this and appear to be recuperating till another hit happens to them in the intensive care or in the postoperative unit. And these can be very simple infections that we have in our critically ill patients, or secondary complications such as rebleeds, reoperations, anastomotic leaks, or the abdominal compartment syndrome, etc. And this again rekindles their systemic inflammatory response syndrome and puts them on the path to this multi-organ failure. And this kind of a classic picture is now kind of a modified by all this aggressive resuscitation that we are doing to our patients. The point is that we need to know when we have accumulated, when we have paid off that accumulated debt of oxygen delivery that the patient has. And we need to know when this is completely paid off so that we do not over-resuscitate. And as you heard Dr. Duchesne talk a little bit earlier, over-resuscitation or attempts at over-resuscitation can be hurtful too. So we need to make this as exquisite as possible. So we need to know that point when we have paid off all this oxygen debt. Now, how do we do that? We could do that by a lot of clinical markers, which may or may not be highly accurate, or we can fall back on some parameters which tell us that the resuscitation is complete. And these are various resuscitation markers we have. You can broadly think about this as global or endpoints or tissue-specific endpoints. By global, we mean that we're looking at the total picture of the patient. We evaluate the total circulation and assess some parameters and calculate the aggregate. And if that aggregate is normal or near normal, we can say that the resuscitation is complete. And the classic examples are the clinical pictures of how the patient looking to you. What are the vital signs? Is he maintaining well? How is his capillary refill? Urinary output, is it adequate? So these are good markers to begin with, but whether they can be 100% sensitive and specific is open to question. So we fall back on some markers that can be looked at as indicators of adequate oxygenation of the tissues. So we can look at the total body lactate, base deficit, how acidotic the patient is, and how is the mixed venous oxygen saturation. Markers like this will tell us if the resuscitation is complete. Lactate has been very popular for about 25 years, and multiple centers have worked with the lactate and showed that this can really tell us how bad the patient has been in anaerobic oxygenation and whether we are paying it off nicely or not. You can see that this is formed by, of course, glycolysis, where the pyruvates are transferred to it through the tricarbic acid cycle to the lactate. And if you have high lactate levels in the patient, you can say that the patient has been through a significant period of shock and anaerobic metabolism. We have good markers of numbers that you can go by. If you have a lactate of greater than 5 to about 15, then you can say that this patient is in very real danger of a mortality of approaching 90%. The other thing is that the lactate nicely responds to you as you begin to resuscitate this patient after controlling the bleeding. And if that lactate does not normalize within the first 12 hours, you can say that the patient may have a high chance of going into multiple organ failure. It is not 100% accurate. You can see that this is the fallibility of lactate because other things then cause hyperlactatemia, and it may not be entirely due to this anaerobic glycolysis. As long as you keep those things in mind, it can be pretty accurate for the most part. Base deficit tells you how acidotic the tissues are and how much of a shock the patient has been through. The initial base deficit is a very good indicator of the magnitude of blood loss the patient already sustained. So if you have multiple trauma patient coming to you with significant acidosis, you can very confidently say that this patient has lost quite a bit of blood and has been in significant aerobic metabolism. And once again, as you begin to resuscitate these patients, it should normalize very nicely. And these are some numbers to go by. If it is a mild base deficit, it's not a big deal. It can be corrected by your crystalloid infusion. But if it is moderate to severe, these patients are at risk for significant need for multiple transfusions. So this is another thing that you want to really keep in mind when you look at our trauma patients in the emergency department, because now there is a significant push to improve our resuscitation in terms of not only blood replacement, but also in terms of clotting factor replacement. Because we really want to give them a very high ratio of blood to plasma to platelets. For that to accomplish, we really need to know how bad the patient has been before he gets to the operating room or the emergency department. So if you have a patient in moderate acidosis, that patient is at risk for multiple transfusions. So you better warn your blood bank, you better get ready to transfuse platelets and plasma in these patients. Once again, it can be fallible because of all these conditions, so you have to keep that in mind and not entirely rely on one number. Mixed venous oxygen tension, which can be obtained by a central venous catheter in the neck, and looking at the mixed central venous oxygen tension. As you know, the ideal mixed venous oxygen tension is from the pulmonary capillary. Not easy to get in our patients in the emergency department, but you can replace by the central venous oxygen tension. Has been very nicely shown about 12 years by Dr. Tom Scalia and his group, and it's still a very good number to look at in patients who have mixed signals of hypotension, normal lactate, high acidosis, etc. Once again, there is a conditions that can be inaccurate, and that is a maintenance of normal SpO2 does not reduce morbidity. So the Eastern Association for the Surgery of Trauma in 2004 looked at all the evidence of all the various resuscitation parameters and came up with these practice management guidelines. Their level ones could not be confirmed because there are insufficient data, but they did suggest some level 2 recommendations, which are attempt to increase oxygen delivery to normalize in 24 hours your base deficit and lactate. And this is a good recommendation, can be done very easily, and I'm sure that most of your centers do follow these numbers, and they are pretty reliable for the most part. Now you can get a little bit more sophisticated and actually look at individual tissues and see how well they're responding to your replacement of blood and resuscitation. You can look at the skin, you can look at the muscle, or you can look at the gut mucosa. Now the most useful so far in 2012 is probably the near-infrared spectroscopy, which looks at the muscle oxygen tension by an easily applicable bedside probe in the TNR eminence. And just to show you some data, again, these are very preliminary. There are no large-scale clinical series that show that by normalization of StO2, you're actually improving your survival. So, but if you look at the data, it nicely points out that patients in significant shock, as defined by these clinical parameters of systolic blood pressure, heart rate, base deficit, etc. And if you look at unblinded, you can look at this tissue oxygen tension in the TNR eminence. You can see that the patients with normal vital signs have normal StO2, and patients who are clinically insignificant hypotension, shock, you can see that they have a significantly lowered StO2, about 50. So this is a good bedside investigation you can do. Once again, like I said, it doesn't have very big clinical data to support it yet as the parameter that we need to follow. And then you can get really sophisticated and actually look at your capillary circulation, whereby you can have a probe under the tongue, and you can see that these capillary structures that you are seeing so nicely here, this is the normal capillary circulation under the tongue. Once the patient is in severe shock and in anaerobic metabolism, you can see a total disorganization of these capillary structures. And you can see the red blood cells flowing very, very slowly, very sluggish. So this kind of a diminished velocity of the red blood cells and the decreased density of your capillary circulation can indicate to you that that patient is in severe shock. Unfortunately, my videos are not working, but when you see a patient like this in shock and put in the tongue probe and follow this microcirculation as you resuscitate this patient, you can actually show that initially this disorganized structure coming nicely back to normal, suggesting that your resuscitation is almost complete. Unfortunately, as I pointed out, none of the regional or tissue-specific endpoints have proven accurate enough yet in establishing the adequacy of resuscitation. So we still fall back on our global parameters. So we don't still have, surprising as it may seem, after 25 years of research and experience, we really do not have yet the last word on what is the optimal algorithm for fluid resuscitation. How much of blood we need to give, what kind of inotropes, what kind of presses, what kind of ratios, blood versus blood components. We are still a long way from it. But we do have some recent data that suggests that the combination of damage control, as we talked about earlier, and this permissive hypotension, in other words, not resuscitate the patients by giving too much presses or too much blood before you control the bleeding. And the idea is that as you increase the blood pressure, it's going to blow that soft clot, increase the blood loss, and would need more resuscitation. So you're caught in a vicious circle. So if you let that patient have enough hypotension to get to a place where you can control the bleeding, and then resuscitate the patients, that seems to be the ideal method we need to follow. And the current data suggest that 1:1 or 1:2 packed red blood cell to FFP ratios are optimal, and this is ideally followed, as we will hear this afternoon, by the TEG methodology. And as I'm sure Dr. Duchesne will tell us this afternoon, and he already told us this morning, that you really need to watch out how much of crystalloids you're giving these patients. Because I think we all have a tendency to overload our patients with crystalloids, and this so-called fluid creep is what is unfortunately very bad for the patients. So thus, the current data on endpoints of resuscitation. The global endpoints may not be perfect, but they are still the best and the most useful, easily done, easily carried out. And despite the large number of endpoints available to the clinician, none are universally applicable. This is a very important point. You cannot look at just one number and make conclusions on it. You have to take the entire clinical picture. And the search for one holy grail or single endpoint that works for all patients may indeed be unrealistic. And finally, I think there is a good thing we need to remember, that we need to look at patients. And a good clinician can make out a patient is not doing well by just going to the bedside, looking at the patient, talking to the patient. I didn't believe this 20 years ago, but as I grow older, I think I believe that more and more. So a good clinician who says something is wrong, the patient doesn't look too good, may be a very valuable thing to look at. So in conclusion then, a variety of markers are available, but there are no substitute for a complete physical examination, experienced, committed nurses and clinicians, and your day-to-day endpoints, common ones that we can measure easily, that will really tell you when your resuscitation is complete or near complete. So, bottom line, resuscitate as best as you can, as completely as you can. Don't under-resuscitate, at the same time, don't over-resuscitate. Thank you very much for your attention.